So if I just, firstly, before I introduce myself, if I just make it aware that we are going to be recording the session today. So if there's any objections to recording the session, if you can let us know in the next few minutes. This is all generic stuff, so it's all helpful for everyone. So it shouldn't be anything personal, which is why we record it and we send it out for everyone to view. So if you don't mind, we're going to do that. And if I can just ask you, keep your microphones on mute while the meeting's going, unless you're speaking or unless you've got a question. That'd be fantastic. Thanks very much. So we'll get going. So Claire, do you want to record? Yeah. Excellent, we'll get going. So my name's Jonathan Henderson. I am a program manager for the primary care workforce team. And welcome to another primary care practice managers forum or event. There is some questions at the end because we know how busy you are, and we really appreciate the system out there is very stretched and everyone's really busy, and we appreciate the time that you take to come to these meetings, and we hope they are helpful for you. We have a bit of a question for you at the end, which is why I'm going to try and keep on schedule with the agenda, and it is just around the meetings, but when we get there I'll come in and there is a bit of an interaction for you to sign in with. So without further ado, I'd like to introduce our first speaker. So we've got an update from the CQC inspector, and that's Ian Jevons. I'd like to introduce Ian and let Ian introduce himself. Okay, Ian, are you all right with that?
Oh, yeah, it's taking time to come off mute, Jonathan, but I'm there. Can you hear me?
Yes, we can hear you. I'll put myself on mute while you're on, Ian. Okay. All
right, thank you. No, thank you. And it's really good to be invited and really good to give you an update, really, on what's, you know, a challenging situation. I just want to say a big thanks, really, in terms of what you're doing, in terms of managing, coordinating, and delivering services in this really challenging time. It's not lost on me and CQC as an organisation what that must be like, and you know, it's not unnoticed. So a big thanks. It's great. Obviously the invite was to just update you on what CQC is doing, and where CQC is up to. And had we had this meeting sort of last month at this time, it would be a different slant. Things obviously are ever evolving, and at the minute, from mid-December, a pause has been put on all routine CQC inspections, and that's in response to GP practices. That is, that's in response to the vaccination program and the demands that were expected to be made on GP practices around the vaccination program. So a pause has been put on all routine inspections until further notice. I don't know quite when that will end, the pause. I suspect it will be sometime in February, but that decision has not been made yet. So until then, all inspections that we're undertaking are based on risk, and it's a very high threshold of risk. We're talking about information that we receive that's risk to life or significant harm, that will lead to an inspection. And unless anything reaches that benchmark, then an inspection won't be occurring. Any inspections that we do in primary care have currently got to be signed off by our chief inspector, with us justifying the reasons why we are doing an inspection, or why we need to do an inspection, and they need to agree that we can do that. So it's a different sort of arena that we're working in the last month going forward. But as I say, I'm not quite sure when that inspection pause will end. We are obviously keeping things under review. The inspectors are currently, a lot of the inspectors are currently helping our adult social care inspection colleagues carry out infection and prevention control inspections to care homes and nursing homes. So you know, we are spending a few weeks focusing on that. And you know, hopefully in the next week or so we'll get more of a clear steer on where we're going in terms of primary care. We are still inspecting independent healthcare, that's less impacted on in terms of the demands and pressures of general practice, where we can, but for the minute, general practice inspections.
Ian, sorry, I think you've gone on mute.
It's automatically gone on mute, Jonathan. I don't know why. What was the last thing you heard me say?
It wasn't me. It literally went mute about 2 seconds ago, 3 seconds.
All right,
It wasn't. It just went on.
I've not touched anything, so I don't know what it just said. I was having a poor connection and then diverted to it. So,
right.
So just to update, before the pause on inspections came in, we had commenced a program of focused inspections looking specifically at access for patients to GPs. And at the moment they're in with the inspection pause, so we're not carrying out any more of those access inspections at this time, and a decision hasn't been made yet whether they will stand those up again once we recommence inspecting. But I mean, the ones that we did do around Greater Manchester were very focused, very short, 1 hour to 2 hours long, with just an inspector, not a GP involved. And they were more looking at availability of appointments, how staff were coping, the range of appointments available, and the reports and inspections that we carried out. The reports reflected really positively about what practices we're doing, and how innovative, and how, even in under the face of such significant demands, that everything was being exhausted every avenue was being exhausted to try and meet the needs of patients and respond positively to patients. So, as I say, we don't know whether we'll be standing those inspections up going forward, or whether, we'll focus on other things once we recommence inspecting. So that's it really, Jonathan, in terms of an update as to where we're currently at. I don't know if anybody's got any questions about those things or anything else.
No, that's great, Ian, and thanks very much for coming and telling us that. So everything's on a bit of a pause at the moment.
It is.
The potential for February, did you say?
It is. Well, at the minute,
potential, and it's
that decision's not been made. But most of our resources are committed to adult social care for the rest of January. So I'm thinking that if once a decision's made with the role, it'll be into February before we, if that decision was made, that at the earliest before we recommence. But obviously, all the time we're taking soundings from Department of Health, from the sector about what life's like and what the pressures are like, and obviously all things are considered when that decision's when that decision's made. Yeah.
No, that sounds great. Thanks very much, Ian. Is there any questions from the group or anything anyone wants to ask Ian while he's here? No. Well, there may be an opportunity, and if anyone thinks of anything, or if Anne comes on next, because we've got a second kind of agenda item around CQC.
I have to go to another meeting now.
Okay.
Jonathan, but if there are any questions, I'll give me email address.
Brilliant.
And then
someone's commented a question.
Oh, have they? Sorry,
yeah,
I've not got the chat on. I've
not
got the chat on. Vaccinations, right. So can we speak about mandatory vaccinations? Is that the question? Yeah. It's deeper there.
Sorry, I was being really vague because I was just
don't be. No, it's fine, deeper.
And I didn't know whether it was the right forum, but I'm desperate for some advice. And when there's somebody in the room that's from the CQC, it'd be really nice if someone could give some clarification. So hopefully everyone knows what I'm talking about. But we're talking about the concept of, I wanted to know the answer to 2 very specific questions. One of the bits of the guidelines that keeps coming out keeps referring to patients / service users, as if service users are not patients. Do service users cover staff as well? From a CQC perspective, when they keep using the word service user, does it refer to somebody other than patients?
The way I would interpret that is they are one and the same thing. It's people that you provide a service to.
Which is what it refers to when you have
in CQC terms, we use both. Because obviously, I think that would be the slant on that. But obviously, the guidance about mandatory vaccinations covers staff as well, doesn't it? It does cover staff, and it covers, it gives guidance.
No, Ian, I'm referring specifically to the
Yeah.
concept of
Yeah.
incidental face-to-face contact with a patient /service user.
So that
So
term, I think with one and the
because
same thing.
there's some real big things. Some people are saying, as far as the CQC are concerned, if you're a 1 second, I just need to pull the door. Some people are saying if you're a CQC regulated business, then your building means that no one is exempt and no one is outside of the scope. And then some people are saying if you can provide a non-patient facing area for a member of staff, then those members of staff could be outside of the scope. And then we've got the query of, okay, fine, we could create that, but then in the event of a fire drill or an emergency evacuation, they would have to exit all through the same place and assemble at the same place, which would then lead to incidental patient, staff mixing, which would then take everybody back into scope. So from the CQC, is there clarity on whether or not a member of staff in a GP practice could ever, unless there's a separate building that never has patients in it, could ever be outside of the scope? That's the clarity I was looking for, because if and when they actually finally pass this, I need to know whether or not there is the ability for a staff member to keep their job.
And to be fair, we're in the same position as you. We've got that guidance to sit and interpret, and we've made no conclusions yet on sort of the end result. All the time we're discussing with Department of Health about interpretation of guidance, ready for April. And I'm sure that over the next few months we'll get further detail on that. But on your question about service user patients being this, they are the same thing in entity. But in terms of the parameters and the issues around staff that might be unvaccinated and what that means for them within general practice, I think over the next few months that does need further unpicking and does need further clarity.
Yeah, Ian, the only reason I worry about you saying months is by the 3rd of February, I've got to issue notice to people if they are in scope. And I can't issue it to someone who's not in scope, because then I'll be open to getting a lawsuit for giving somebody notice that could have been exempt.
Those are the questions that we're asking as well.
Yeah, it's just a deadline. I mean, it's by the 3rd of Feb. I need to have done that. Yeah.
Well, I mean, I can't speak on behalf of the Department of Health about what the outcome will be of all that discussion, but I appreciate the circumstances that you're under, because I know that different practices and different areas have been taking legal advice on how to proceed.
And like I say, so just from the CQC perspective, about whether or not it was physically possible to count somebody outside of the scope if they work in the building itself.
I wouldn't be able to comment on that at the minute, because I just think that the guidance is there. It talks about exemptions currently, and the parameters around it. There's guidance about what the parameters are around exemptions, but not a lot about the detail of what that means in terms of proximity and how practices would be able to manage those staff that are vaccinated and those that aren't. Because in that guidance there's also obviously the expectation that providers protect staff as well as service users and patients.
Right. Ian, there's just obviously there's the conversation, and I think there's conversations around the conversation in the group, which is it is around the guidance, and like you say, I think the guidance is not that clear for you guys. It's not that clear for us guys at the moment. People are saying, and I have heard this myself, if obviously the 3 vaccinations process would have to start in January. If they were going to have the 3 vaccinations like it's stated in the guidance. However, obviously if the guidance is going to be interpreted over the next month or so, it's going to miss that deadline.
This was mentioned on a meeting I was in this morning, and quite quickly we appreciate that from a regulator perspective, we're going to have a steer and a sort of a public statement as to where we stand and how we are interpreting what guidance there is. But I'm not in a position to be able to say what that is. But we are aware that something must be produced in haste.
Yeah, definitely. And I hope you don't mind. We've Claire's beat me to it and I had it ready, but we've just put your email address in the chat, if that's okay.
Yeah, no, that's
Now,
absolutely
obviously, that's
fine.
just for
And
people who
if
want
I
to
need
contact
to,
you.
you know, if there are any further questions, I can either answer them myself or pass them to somebody that I know can give a better answer.
That's great. And if you do hear any changes in the guidance, Ian, if you could forward it to
Yeah,
either of us, and then
do.
we can get it circulated into Greater Manchester as a general.
You know, and just to be rest assured, in the meetings that we're in, we're having the same kind of debates around that, and the same questions are being asked. So it's not on our radar. It's that we're trying to get clarity, to provide clarity. But at the minute, we're not in that position that we're able to do that.
Yeah, no, that's fine. And if we can keep connected, if you like, throughout this process, because I think every organisation's in the same boat. And I think things have been quite quick, as in the process, even going down to vaccination and the issues that we've had. So I know the pressures out there are pretty strong. And when you're trying to plan for something that's coming, it's not really fully foolproof.
Yeah, and it's not always easy, because in respect of care homes and nursing homes, and the other stuff linked to the NHS, the guidance and regulations are worded in slightly different ways. So there are legal people scrutinising what the differences might be and how that might be interpreted should people take it forward under law. So it's not it's something that there's got to be debate about.
It's not an easy process, is it? What we're asking people to do? No, it's not.
And gentlemen, can I rudely jump in with one final point that we may need to consider? I've had a member of staff raise an issue that she's gone back to her insurance company because she heard a rumour that insurance companies will not pay out if something happens to you because you've been vaccinated, because it's a voluntary issue, and that the risks are widely communicated. Now, this is a major problem, because what she's saying is, because of her health conditions, she really does need to make sure, for her family's protection, that she has this insurance. And I've been asked whether or not, what compensation or what reimbursement would there be in the case of her being harmed to the point where she couldn't work. Clearly, I can't give that guarantee. And again, February is rapidly approaching. Well, and I've no idea where we go from here with this.
No, I appreciate your position. And I think that'll be, there'll be many practices and many people in that position that are having to deal with individual circumstances of people that they're trying to unpick and work out a slant on how they're going to proceed and progress it. I think it's difficult.
Really difficult. I can have a look and take that away, Roy. If you want to email myself with the query, and I'll put my email in the box. And if you can email me, we can take that forward. I can take it somewhere and I'll find out.
Excellent. That's just for you. It's one of many questions, unfortunately. So I will say.
Yeah, no, that's fine. And I'm just thinking if we can get them logged down, because I know we will be. It's like everything else. It's a lessons learned. This is the first time we've ever been through this process. It's a difficult one because you've got beliefs over. I'll not go into it because I think it's an argument I don't want to go into. However, it is a difficult situation, and you're going to get 1,001 different circumstances through it, I'm sure, and this will only grow. So if I can get it logged down and get it to me, then I've got something to take, and we can start making logs. I'm sure that we are logging all these separate issues. Well, that's fantastic. Is that okay, Roy? Yeah, if we can take it down that direction.
Yeah, no, that's excellent.
Yeah, no, that's brilliant. And Ian, thank you very much for coming today and speaking.
Yeah,
to
no
us.
problem.
It's very formative.
Yeah, no problem. I'm happy to come to other meetings that you've got if that's helpful as things progress. That's fine.
That'd be great, Ian, and thank you very much for today. And I can let you go. You can go. All right, sir.
Thank you.
Thank you very much.
Thank you.
Take care, Ian.
Bye.
Right. Okay. Well, thank you very much for that. And that was a really interesting. Oh, have we got a question? Have we got a hand up? Or is that a legacy hand?
No, it's a new hand.
Was it to Ian?
No, he's already
Right.
got. It might be more for you.
All right. Okay.
Hopefully, Jonathan. I've been speaking to other practice managers who have spoken to their own HR. Because contracts won't be identical across Greater Manchester, and because HR advice won't be the same, some may be more cautious than others. The only viable solution would be a centralized bit of advice from GM that would cover all contracts and any HR advice. The variation between HR advice across our patch is fairly significant, and I'm assuming it would get wider if we started to consider HR advice being offered across Greater Manchester. So whatever's issued has to cover a range of contracts that won't be identical. Some might be outdated for older members of staff, and HR advice that will vary across the patch as well. So if we could get a coverall, that's going to work. Otherwise, we'll have practices effectively isolated, which isn't great at this time.
That's brilliant, and I can take that forward. I think I know the group that I'm going to take that to, which is our vaccination group and stuff, that are looking at all the issues that we're having at this current moment, especially around the announcements of contracts and stuff that are going to be changing in the near future. So I think what I can do is, again, if I can get you, SF, to email me on that email address just with the query, I can take that forward, if that's okay. And yeah, I think centralised advice is a good idea from GM to pull things together.
That'd be great. Thanks, Jonathan.
Yeah, no problem. All right. No, that's great. Thanks, Eddie. Right. Okay. So if we move on now, if I introduce Anne Goff, and Anne Goff is from the GM Excellence team. And Anne Goff is going to, I'll let Anne introduce herself. And Lorna, is Lorna with you, Anne?
Yes.
Yeah, and Lorna will introduce herself. And they're going to prepare you for a QC visit. Is that right, Anne?
Yes, absolutely. So
CQC. I said QC, didn't I?
CQC, yes.
CQC. I'll let you go.
Hi everybody. I'm Anne Goff, the programme lead for GP Excellence, and as ever, great to hear from Ian and sort of from the horse's mouth on what's going to happen in respect of CQC. But I think we've all got to be mindful that at some point in the not too distant future, CQC visits will start again. And we're very aware from previous data that we hold that many of you haven't been inspected for a considerable amount of time. Some going back to sort of 2016, 2017. Many of you won't have been inspected under the new regime, where things have changed significantly since your last visit. The CLOEs have changed, the focus of the visits has changed. They are invariably virtual now. It's not like the old days where the CQC team used to come in and look through the files and everybody would sit in a room and have a conversation about the evidence that you were able to provide. The majority of the visits are now undertaken virtually. So with all this in mind, and we're very aware that there's no good time for people to be attending any training, but we have, through our connections with the RCGP and Lorna, our RCG practice advisor, who has lots of experience around CQC, we've put together, or we're in the process of putting together, a series of webinars for you. The webinars are only 3 hours long. We're aiming to start them sort of mid-February through to March or beginning of April, however the timing might work out. And we're looking to offer them on a locality basis. So we're in conjunction with the RCGP and their specialist CQC advisors. So we're hoping to put together a really a good programme for you. The programme will cover each of the 5 CLOEs and also go into detail about how best to interrogate your access data and start to look at your access data. But we'd like to take the opportunity today, and Lorna's going to speak in more detail about what the what a visit might entail and what it might mean for you as a practice manager. But what we'd like to do is to hear from you anything that you would particularly like to see within the content. We're just in the throes of finalising the content with our ICGP advisors, so there is an opportunity to influence that. But bearing in mind that we've only got 3 hours during the sessions, so I'll hand over to Lorna to kind of talk about what the visit might look like, what the visit might entail for you, and we can answer any questions on anything CQC related. Obviously not going into the detail of what Ian goes into as a CQC inspector, because we don't have that level of information. But we'd really like to, obviously we'd love you to attend the webinars. The invite will be going out in the very near future. As I say, we're going to be doing them on a locality basis. So we want as many practices as possible to attend. But your opportunity really to influence the content of the course, if there's anything specific that you're concerned about and you would like to see covered outside of the Chloe's and access. So I'll hand over to Lorna, who'll talk you through the next bit on really the important bit on how best to start preparing.
Thanks,
Lorna.
So for those of you who don't know me, I'm Lorna Laughlin. I'm a practice manager working over in Lancashire, but I've also worked as an advisor for the RCGP for just over 6 years now. And my role with them has predominantly been supporting practices who have found themselves with either a requires improvement or an inadequate CQC rating. When that happens, the RCGP sends a team in, usually just a couple of us, usually GP alongside myself, but it could be a nurse as well. And depending on the areas that require improvement, we can support the practice for up to 6 months at a time, helping them gather their evidence showing their improvement and ready for their re-inspection. The team that are setting up these webinars are all experienced advisors and are used to working directly with practices who have been through a difficult experience with CQC inspections or are worried and need preparing for that. So they've loads of experience. And the webinars are a bespoke package that is being built, just for you guys. So it will have really timely, relevant information for you. It's obviously going to cover all the Chloes, and some of them will probably go into more detail than others, because some of the areas you probably feel really comfortable with and you've lots of evidence, whereas maybe some of the others you're not quite sure how to evidence certain areas. So the team will cover all those for you. We've also asked them to put in a bit around access, because although the CQC have halted that for the moment, we know access is going to be on their radar, and it's something that we want you all to feel prepared for and to be able to justify your data. Now we have to, now we've been through the appointment mapping process, and that will now become some of the intelligent monitoring data that the CQC will have access to prior to coming out to do your inspection. So we want you to feel prepared and able to justify, why your model works like it does and how that best suits your patients. In addition to that, if there is anything at all that you think we really do need to cover this, we'd like some time to focus on that, then we can take that back to the team and ask them to build that in. So I've already made a note about the mandatory vaccinations and what the advice would be around that. Clearly, that's a fluid topic at the moment. We are waiting for the legislation to be finalised, and maybe will give us a bit more clarity around it. But for the moment, as somebody said earlier on this meeting, we have a deadline looming and we're not quite sure what we're going to do with that yet. And it's probably better if primary care or certainly localities can come together as a whole and look to do that. I can see someone's already putting something in the chat about ideas. That's a really good way. If you want to pop things in there, I'll pick those up at the end of the meeting. So the webinars, it doesn't matter whether you're a practice who's worried about going through the inspection, or you're a practice that has previously got an outstanding rating and you feel you've got everything in hand, you just want some reassurance. I think everyone is going to get something out of these sessions. And hopefully the more people that attend the sessions will be able to, it's going to be interactive, and you can pick up so much from your colleagues as well, and some ideas of best practice and how other people are tackling things. So it should be a really good experience for everybody. As Anne said, a lot of you won't have been through the new style virtual inspection yet. And, we're hoping that this session will help prepare you for that. So give you some ideas of how you can evidence the good work that you're doing within practice, and how you'll be able to demonstrate that either through sharing screens or having information ready that you can send off to the inspector when asked for it. We are hoping to roll these webinars out quite imminently. I spoke to our clinical lead yesterday, and they're hoping it's going to be the end of January at the beginning of February when the first session will be launched. And as Anne said, we're going to deliver them via locality, and we're hoping to probably get all the sessions finished by the end of March. But I am aware as a working practice manager that there are really busy times coming up, and we're all under immense pressure. So if there's any weeks that you think that really won't be a good week, it's year end, or we're going to have submissions due and we're just not going to have time out, then again, if you let us know that, we'll try and work around schedules that will suit people. So, as I said, we're running this through localities. There's going to be space for every practice to send a delegate, and we hope you all take that option up. We can't guarantee there's going to be more spaces available for, secondary members of the team. But if we do get some practices that don't attend, then, we will offer that out. But at the moment, it's going to be one delegate per practice. We're presuming in most cases that it will be the practice manager who will attend. But we understand that in some practices there may be someone else who you think will be more suitable. That's fine. There's no restriction on which member of your team attends this. Just pick somebody who will be involved when you do have an inspection, and will be happy to feedback anything relevant to your practice team from the webinar. Again, the webinars will be recorded, so you should be able to pick it up afterwards if you were unable to make your locality session. We are really excited about these sessions, and I do believe they'll be really worth your time in attending, and I know firsthand how busy you all are. The only other thing I can think of to mention at this stage is that whilst we're hoping these sessions will help prepare you for the upcoming inspection, we've no control over when you're going to receive an inspection. So it was reassuring to hear Ian's earlier presentation that he recognises and the CQC understand the challenges we are facing and are taking this into account. When they're arranging their inspection schedule. But he did say that they don't know what's happening from February, and that's only a few weeks away. So I would really urge you all not to wait for the sessions before you start to plan or begin to prepare your evidence, as it's possible some of you, could be given an inspection date before your session. Also, any evidence that you begin to gather, you'll be able to benchmark against what you're told in the session, and hopefully it will be reassuring for you. So I think that's everything, and that I have to add. If anyone has any questions, I'm happy to take them.
Oh, thank you very much, Lorna. There is a few questions. I can read them to you. I'm not sure I'm fully on board with them, but you're the CQC people. So can we get some help on the remote searches for the CQC we'll be doing before an inspection? Is that... I
can take that back, yeah. There'll definitely be some good tips on the type of searches that you can be running and have to hand for when they do the inspections.
And I think they talk about a similar thing. Are these virtual meetings different to the telephone CQC reviews that had started prior to the pandemic? And that's from Sharon.
My understanding is slightly, the format is going to be very similar, but a lot of that was, they were, for want of a better word, mini inspections, whereas this is a new way of doing a more detailed inspection. Now, from what I understand, they're going to be focusing on a lot of the intelligent monitoring data, and as you said, high risk patient safety areas. But as we all know, if we've been through a CQC inspection, as you start to open up those conversations and you start to discuss things, it can lead on to other things and they'll ask for other evidence. So I would prepare yourselves as if you were going to do a full inspection, cover all areas of the Chloes, but virtually. So, you don't really want a big stack of hard copies of things that, you would normally go through and show them. Think about your last two recruitment you know, maybe get those things scanned on and available to share if you need to. You know, anything that you can have to hand that you can either screen share or you could email over will help you and will reassure the CQC that everything's in hand.
Yeah, and you've got your hand up. Oh, sorry,
just from previous conversations with Ian, and he did attend one of the delegated management meetings over the summer when practices were still being visited. That they're invariably doing the visits kind of in the same way that we're having this meeting via Teams, via Zoom, as well as picking up the telephone. So they are more concentrated than just the telephone conversations that have taken place previously. And as Lorna says, the majority of all of the information is will be submitted electronically to the CQC. So what Ian was saying is they are more protracted really than obviously the CQC team just going in and spending a day in the practice and talking to lots of different people. There's a lot of backwards and forwards on sending information, the CQC reviewing it, and then potentially coming back to you, asking for more, for more evidence or for you to provide more information. So they are more long-winded and probably, I'm not saying more stressful, less stressful, but probably take place over a longer period of time because of the way they're conducted. It's not just that CQC are coming today and that's it. We've boxed it off. I think the process is longer because they are virtual and because of the way the information is submitted. But just going back to the searches, obviously you'll want to run your own searches, but CQC do have virtual access to your computer systems. So CQC will do their own interrogation because they have virtual access to the clinical systems.
Right, thanks, Anne. We do have a few hands up, and I'm not sure on the order because I can't see the hands and when they came up. So I'm quite trusting on people. Whoever put the hand up first. Apologies.
Has Karen been?
No, I haven't asked my question yet.
Right.
I was just wondering if anybody had ever used any external organisations or private companies or anything like that to give them some guidance and help, in preparation for the visits.
Is that, sorry, Karen, is that aimed at the rest of the practice managers or us? Is that an open question to see what other experiences are? Right,
yeah.
Okay. Right. Is anybody?
Karen, I actually used to do that. I was a specialist who'd get people who are in special measures or requirements, get them into a good. So, and I have a lot of, I know a lot of the inspectors and what they're looking for kind of things and how they're changing and stuff. So if you want to use me, by all means, it's called CPC Help. But they have changed the way they are investigating. Basically, they are looking at the national information on access. So that's one of the key areas. They're looking at your DMALs and DOACs. They're looking at your registers, say, especially for diabetics, anyone who's not been put on a register who should. The clinical pharmacists are getting a lot more involved. It's becoming a lot more clinical pharm. The population groups are kind of going away from. So if you're looking at those key areas and anyone who's not had a review in over 12 months, that's what they're really focusing on.
Right. Does that answer, Karen? Is that okay?
Yeah, I actually don't even know who was speaking at that point, but who was it?
That was a teacher, is that right? Am I wrong?
Yeah.
Yeah, no.
Okay,
Yeah.
thank you very much.
No problem.
And Aditya, I think you were second in line with the questions as well. So if you want to come in with your question.
Yeah, I was just going to ask Lorna, have you had a CQC recent inspection? Is that what your data is coming back from about how the CQC have changed? Or is it just through the webinars kind of thing?
So, I don't know if it's lucky or unlucky, but my last inspection in practice was 2016, probably like a lot of you. So no, from a manager point of view, I'm going to be going through the inspection process. From the RCGP side of things, we have a number of practices that have been through recent inspections that we're supporting. We speak a lot to the lead inspectors in those areas. It's a programme that's run nationally, so we don't just base ourselves in our local area. You know, we can go across the country, so we get a feel of how the lead inspectors are dealing with things in different areas. And also a number of the advisors that work on our programmes are also CQC inspectors, so we do get some information, you know, quite timely and first hand from them. We also attend, as you all can, the webinars that the CQC do. We listen to information that's coming out, and then it comes down to interpreting that and deciding how best practices can evidence that information, because a lot of the time they'll tell us what they want us to do or what they're monitoring us on, but then they don't tell you what is acceptable when it comes to what evidence you should submit. So as a team, we try and guide practices and support them into being able to demonstrate that under inspection circumstances.
Right, yeah. Because I've been a specialist advisor when it was the National Care Standards Commission. So the last inspection I went through was actually August, but these were ones who were like at risk, who were kind of requires improvement and stuff, or inadequate. So their inspection method is that they would get a visit compared to people who are good and the monitoring stuff is good. So if you're in
and they can still use a hybrid model if they feel that's necessary, if they think they need to be on site. It doesn't have to be 100% virtual, but I think in most circumstances, and certainly for practices that have previously been rated good, then they're going to go with the virtual model first of all.
Yeah.
Our webinar is going to be focused, you know, on maintaining your ratings, potentially improving your ratings, and obviously if it's something you're worried about, or you know you've been in a RI requires improvement situation before, you know, helping you ensure that, you know, you're resilient this time around and you're going to be able to demonstrate that.
Okay, thank you.
Thank you very much, Tat. So if I can just ask, Karen, is that a legacy hand that you've got up? Because I think your hand's still up in the air.
Sorry, apologies.
No, it's fine. If I can just, I have trouble as it is. So I think we've got a question from you, and then is that right?
Yes, thanks. If you consider how important these inspections are and what the potential impact of a negative experience would be, one would think it would be reasonable for us to have received some form of written, I don't know, guidance in advance of what the changes are. I don't seem to be aware of anything that's been issued by CQC or from GM, but it would be useful either in advance of the webinars that we're planning, or if there's anything shareable elsewhere. I think it'd be helpful for us to have an understanding of what the changes are and what kind of questions we will be exposed to. If we understood the nature of the interrogation and how they changed, that would help us prepare. And it seems a bit odd that we've not already been sent that. However we're inspected in COVID, it will be significantly different to whatever our experiences were previously. We were inspected in 2017, and so much has happened since then that it's a little bit surprising that we've not been sent a guide or a pack or some kind of preparation that will support us in actually preparing for inspection.
Could I just interject there, Asif, if you don't know? have you signed up for the CQC alerts? Because they do give a lot of information, like from April 2021, all consultations, you should be offering a chaperone for every single consultation. And it's those little things, the new things, the CQC will look at. Are you updating your infection control to the latest version? And I understand what you're saying is that things have changed via COVID, but that's not how they're seeing it. Maybe it's just the inspection kind of method which they use, but they're still expecting the same kind of quality evidence. You're still doing your audits and you're still putting your actions. It's what really gets people down is say they do an audit, but they will never, follow through with their action plan or actually address it. So it's those things, So it hasn't much changed besides the method of coming in and going through more of a clinical pharmacy way. And if you're ready for a full inspection, because even if you're rated good, they could still send someone just to do just a site visit, just for an hour or so, just to make sure that all your drugs and consumables are in date if they have any doubt. So I don't know if that helps you at all.
I was actually wondering if there was anything that had been sent out either from CQC or from GM that would act as a guide and a form of support for us.
Alan, are you aware of anything that's gone out?
Other than the CQC can constantly update their website with their latest information. So that's obviously the best place to start. And we know what the flows are. We know which areas they're going to be coming in and looking at. So it's quite prescribed really in terms of that those are the CLOEs, and that's the evidence that you're going to have to provide against each of those CLOEs. And yeah, the CQC bulletins that come out always give the regular updates. From a GM point of view, we wouldn't really want to send anything out that that was contradictory to what against what the CQC might come in and ask for. I know during the webinars and as part of the webinars, the RCGP are going to make available to us their preparation handbook. Now, I haven't seen it personally. Lorna has, and from a practice manager perspective, says it's absolutely excellent. So I think I can only encourage you to join the webinar in your locality. Go through meet with the RCG providers, who are very experienced, the advisors, who are very experienced in this field. And then ultimately they're going to share their preparation handbook, and we're hoping that's going to be a little bit of a Bible for everybody in Greater Manchester to be able to start preparing and take their visit forward. But no, we haven't sent anything out specifically. We do rely on the information that's coming out from CQC themselves.
Their website.
The first way is just to read the inadequate reports of recent. You can always learn from their mistakes. That's what I do.
Absolutely.
Lessons learned.
Is there any chance that the RCGP workbook can be shared before the webinars actually start?
We can take that back and ask that. We're certainly not holding on to it for any other reason, but I think part of the reason of us coming to this meeting today was to make sure that we're covering everything you want us to cover. So it might be after this, there'll be a section added about, if it doesn't clearly advise you on some of the searches to have to hand, we'll try and get that put in there, and if there's other information. So as long as we can get that finalised timely enough to share it with you without it just being an hour before, we will try and do that for you. If not, we will certainly have it. It is a really good document. I've seen the first draft of it. It's excellent. You will certainly it's going to be useful for me in practice. just using it as a checklist really, and making sure that we've got all the evidence that we need to demonstrate the close at the moment. There's always things that change though, and you know, access is the big one this year, isn't it? We're looking at that now. That won't have been in previous ones, or it will only have been touched on, whereas I think there's going to be a big focus around that now. And it's the same with some of your drug searches. If you start thinking about things that, you know, monitoring and maybe have been a challenge, particularly if, you know, you need to do face-to-face assessments for things like that, they're the kind of things that they're potentially going to be looking at. So we don't always know exactly what they're coming in with. Even the inspectors on our team won't tell us 100% this is all the things that we're going to check. And a lot of it will generate through other discussions and will lead on to stuff. So it's just making sure that, you know, you are able to evidence in anything that you think is a high risk drug, anything around safeguarding, anything that, you know, has been challenging whilst we haven't been seeing everybody face to face, you know, other things to focus on. But we'll go through. When I say we, I don't think I'm actually presenting on the webinars, but certainly the team will go through everything with you and make sure that, you know, you certainly feel a lot more confident for when you do get that inspection call after this.
Thanks, Lorna. And I think you've put your question that's in the chat, your Mentimeter question, if you like, your pre-populated question that people are replying to. So we've had quite a lot of replies. Is what you've just said, Lorna, I think at the beginning of your response was, is there anything else that we would like to see within the webinars, which is in that? So if there is anything that you'd like to see, if you can fill out that questionnaire that's actually in the chat at the moment, and then we can take that away, can't we, and have a look at that as well.
Only if people got our contact details, if they want to contact Lorna and I directly, I'll put the generic email address in the box, and then both Lorna and I can pick them up.
That'd be brilliant. And we just had, well, we did have one question, but it seems to have fallen off. Was it a lift? I think. Was it? It might not be a question anymore. There is one in the chat, and I'm not sure if it's for you ladies or it's a bit more for Ian and the CQC itself. And it's Anthony Howard who's put it. It would be really useful to know what data they will be remotely looking at. Also, who has given them access to my clinical systems, and how do I check this isn't being abused?
Okay.
So I think that may be a question for Ian or Lorna or Anne. Do you know around the data retraction?
From what I understand, the only way they can look at your access data, sorry, is that what you're talking about, Anthony, or is it something else? The only way that they can look at your access data is through the appointment mapping, which is now being extracted. Personally, I've got real concerns about that. How we've all mapped our systems will be different, and how we are ranked in order. I think that's maybe one of the reasons why they've halted it, is because maybe it isn't as accurate as it should be. I'm not sure how they're going to do that. We do all run different systems, and I don't see how we can get to a point where we all align everything just to make it easy for intelligent monitoring data. But they're certainly going to be looking at that. So making sure that, you know, you've mapped those areas correctly, and that your staff, when they're putting your rotas on and your appointment schedules, are using that properly, and you're able to maybe make a note if it doesn't look like you've got any available face-to-face appointments, or, you know, you're not offering video consults, or however you're doing it. And understanding your own personal ratios of these things will be helpful if a discussion comes up around access. The other data that they use is what has always been just your historical data. So all your prescribing data, that's out there, you know, your CQC have access to it, your CCG has access to it. Open prescribing, I think, is the website, and you can go on and see where you sit with there and whether you're outliers in any areas. And then some of just the national, like cervical screening, bowel screening, you know, some of the cancer data sets are out there. So there's a lot of information that are already extracted. If you have a look on your clinical systems or on your the ISG, that should be able to tell you what you've agreed to sharing for. But when it's contractual and it's regulatory, they are entitled to ask for information as well. So some information they'll have prior, which is the intelligent monitoring data. They can get that. They can see your, you know, they can go on NHS Choices. They can see the type of reviews that you're getting. They can see, you know, if you're likely to have generated complaints, how your patients are feeling. They can go on the open prescribing. As I said, your cancer areas. They can see all that prior to coming in. They can get information from your CCG, how you look and how you sit ranked within your quality contracts or markers that way. But then also when they contact you, they can ask you to run specific searches, or they could even run them on your system and ask for access. And we have to give them that access as, you know, as our regulatory body. So the more you understand your own systems and know what's on there, the better. For those of you who are using Ardens, the Arden search packages are really good. If I'm on EMIS, Ardens works really well with that. Don't know about other practices that are maybe on a different system. If you have access to that, certainly it works really well for us. So that might be something to think about, particularly if you have access to Ardens. Start to look at some of those searches and see what's available, because they'll be familiar with those and they'll be able to use your system if you have Ardens on there to extract the data that they're interested in looking at. Does that help?
Thanks, Lorna. I think Anne's going to put the contact in as well. So if there's any further questions, I'm sure they'll be able to contact you, if that's okay, Lorna and Anne. And I'm just going to swiftly move on and thank you very much for coming, because I think the CQC has been a real focus point at the moment, and I think we've got a lot about today, so it's been well worth it. So thank you very much, both of you ladies, for coming in.
Thank you. Bye. Bye, everyone.
Thanks.
So I'm just going to swiftly move on. I'm going to introduce our lead nurse for Greater Manchester's Community and Primary Care Services, Leslie Royal Pryor. And Leslie's coming today to talk to you about the Healthcare Support Worker Passport that's been currently being created, and update us on that. Is that okay, Leslie?
Yeah, thanks, Johnny. Thank you very much. I don't know how I can follow on from CQC really, because that's massive, isn't it? So here we go. Healthcare support worker development, this is about. So it's just really an update for you and to ask you a little bit of some of your advice really, and support. We're all aware that healthcare support workers are a massive resource and a wealth of support for our patients and for our staff teams. You may be aware that in Greater Manchester we've been piloting a healthcare support worker foundation programme for the past 12 months. The 6-month fully funded course was developed as a supporting measure initially for winter pressures last year, and it was to develop new and aspiring healthcare support workers. It's been really well received across Greater Manchester in all areas, and we've seen over 100 healthcare support workers go through the programme now. Some who have developed further, some have stayed of healthcare support workers, and some who have developed further to go on towards nursing and nurse associate training courses. So what we'd like from you today really is your views now on how we can further develop this programme on a digital level, that we would provide a similar standardised foundation level training via the Greater Manchester Passport. The changes we would be looking to are that the programme would be on an ongoing modular basis with a variable step-on approach. So your new or aspiring healthcare support worker could come onto the programme at any time that they started working with you. There was no set dates. You would be able to decide not only at what point they start the programme, but actually at what module they would start as well. So nothing would be set in stone, if you like. Once completed, the programme would generate a certificate on the Greater Manchester Passport. So therefore that would potentially allow that healthcare support worker to move across Greater Manchester practices with the practice gaining the assurance then that their new healthcare support worker would have completed a comprehensive training programme. We're hoping to have the digital programme ready to be viewed for the next meeting here, if that's something you'd be interested in. And I'd be really interested in any ideas or comments you'd have on that. That's me done, thank you. So any questions?
Thank you very much.
I can't follow on from CQC, you say.
No, I thought it was really good. So this is sorry, go on, Isaac.
I'll pop my email address into the chat, and then if anybody does have any ideas or suggestions or wants to get involved, with its development, I'd be really interested for them to do that. So thanks.
Oh, that's excellent. And I gather if we've had 100 go through the system already, Leslie, these are all from practices.
They are.
So the practice should be quite familiar with this.
That's right, yeah, with the programme. If anybody wants to know about the programme, we can send those flyers out again. There are still places on the first programme, but we want to see if we can make it digital so it's easy accessible for everybody.
Yeah, sounds really fantastic, Leslie. Yeah, sounds really good. We have got a question from Lindsay. Lindsay Philby.
Hi, Leslie. Nice to see you as well. I've not seen you for a long time.
Hi, yeah.
Hello. Just a quick question. I employed someone as a phlebotomist who has kind of been developing down the HCA route, and she's actually excellent and making good progress. I just wondered what the time commitment was, because we only actually employ her 2 days a week. So it was kind of like, would she need to do additional hours to complete this programme if we were to send her on it? Or is it quite flexible how she can do that?
So at the moment, the course is running, I think it's 1 day a week, but this is the reason why we want to try and get it digital really, Lindsay, so that it's easy accessible, so that you could actually do it any time. So that you could decide what you wanted her to learn. So it runs along the RCGP guidance for healthcare support workers anyway, with the competency sign off. So there's a phlebotomy element and there's a cardiovascular element to it as well. So they would learn about hypertension reviews, taking a blood pressure, urinalysis, NHS health checks, things like that. And we're looking at like an IMS and VAX type of update as well within that. So it'd be quite a comprehensive web-based learning programme, really.
Oh, that sounds really good. Yeah. Right, thank you.
Thanks very much, Lindsay.
That's brilliant. Thank you very much, Leslie. It sounds really supportive as well of the services that we need. So no, brilliant. Right, and are you going to put you've put it in, so that's brilliant. Leslie, just double check that email address. Right, anyway, so we'll swiftly move on, and I'd like to next introduce you to Lovejit, who's here. Is Lovejit here? And Alison.
I'm here, Alison.
Hi, Alison. Oh yeah, sorry. I had seen you on my screen. It just, your name didn't come up. So hi, Alison. It's lovely to have you along here. So Alison and Lovejit, or Alison is here from. I'm going to talk to you or update you around the GP Community Pharmacy Consultation Service. Right, Alison?
It is. Yeah, fantastic. Thanks very much for having us. Yeah,
okay.
I really appreciate it.
I'll let you get started.
Okay. I've got some slides. Am I okay to share screen?
Absolutely, yeah.
Brilliant. And my colleague Lovejit's just joined, so we're going to take you through the slides between us. Lovejit's got the first bit, and then we'll do a handover in the middle.
Wonderful.
Okay, hello everybody. I hope you can hear me all. Yeah, just make sure. My name is Lovejit Kandula. I'm Director of Pharmacy Transformation for GMRPC and Chair of Community Pharmacy Provider Board. Hopefully Alison's given an introduction to herself. Yeah, have you done that?
You just joined as we were about to do it, so you can do my intro if you don't mind. Thanks, Lovejit.
Yeah, so I'm joined by Alison Scowcroft, who is our project management lead for the GPCPCS project and also works as Director of Strategic Programmes for CHL, our provider company for community pharmacy. And so we'll be doing a duo today, so you will see some handing over. So this slide deck is around giving you an introduction to GPCPCS, and hopefully by the end of this session you will have understood what the service is, what the scope of the service is, and a lot more detail around how this service is going to work in Greater Manchester. And we will also have a Q&A session at the end for you, so please jot any questions down and we can answer them at the end. So I'm just going to start with a little bit of background. So the NHS Community Pharmacy Consultation Service is a nationally commissioned and funded service that was launched in community pharmacies across England in October 2019. So initially this project was involving electronic referrals being sent from NHS 111 to community pharmacies for patients with a minor illness or those needing an urgent supply of medicine. Then a decision was made to expand this pathway to general practice. So patients with minor illness could be referred from general practice as well. And this was piloted by NHS E&I across a number of areas in 2019 to 20. The decision to expand this service to include referrals from general practice to community pharmacy was agreed as a nationally commissioned service from the 1st of November 2020. So what is Gpcpcs? GP Community Pharmacy Consultation Service is a pathway that general practices can use to refer patients with minor illness or low acuity conditions to a community pharmacist. The patient has to be referred electronically in this service, and when the patient is referred, they will receive a consultation with a pharmacist in the consultation room remotely, where the pharmacist will clinically assess the patient, refer to the summary care record and NICE CKS guidelines. And just to note here that this is not the same as a conversation over the counter. There is a national service specification that defines very clearly how this service needs to be conducted, and it must be conducted by a pharmacist. So only patients electronically referred from general practice or NHS 111 can be included in this service. Next slide, thank you. So in terms of evidence and impact, and just to provide some assurance as well, in the NHS 111 CPCS service, which has been running successfully now since 2019, 10,500 patients are referred per week in England already. And to give you some example of the numbers, 332,000 patients were referred in the first 9 months of the service from October 2019. In the pilots that took place across the country, 88% of patients referred had their concern resolved by a pharmacist, and it is projected that general practice community pharmacy consultation service could save potentially 20 million, or more importantly, 6% of GP appointments, which can be safely referred to community pharmacy. So the GP referral pathway, as I discussed previously, was then introduced following a successful pilot and evaluation by NHS England. Next slide. So in terms of the benefits, as general practice continue to deliver the COVID-19 vaccination programme, we know that you are facing increased amounts of pressures all the time. Your workload has gone up, and we hear a lot of this feedback from general practice colleagues that we've spoken to, and the greater use of the pharmacist's expertise can help ensure patients are provided with the right care by the right person at a time most convenient to them. And this will increase capacity within general practice for the treatment of patients with high acuity needs, both now and post-pandemic. So the service aims to support the local NHS system and improve access through primary care through more effective use of existing resources. So for patients, it should result in accessible and professional clinical service from the pharmacists of their choice. And in the long term, it will re-educate patients to go to the most appropriate healthcare professional. And for general practice, it should create more capacity, so more GP appointments are available, and those with minor illness conditions have been referred to pharmacy, and it helps to build on enhanced local relationships between primary care providers. I just want to stop there for a second and just say that we are in the early stages of implementation of this pilot, this service now, and we've got extensive engagement. I think over 80% of practices have now engaged, but the early stages of the project, there are obviously teething problems, and so we are working through those at the moment to make sure that community pharmacy are referring back appropriately, and also that general practice are referring the correct things that community pharmacy can deal with. Next slide. So in terms of the GM referral process, so just to provide an overview of the process that we've agreed to with the partnership here, a referral is sent electronically from GP to pharmacy. The patient is told to wait for contact from the pharmacy, and the pharmacy will contact the patient within 2 to 3 hours. If the patient does not receive any contact within 2 to 3 hours, they will be provided with the number and they can phone the pharmacies. Any referral sent by 2:30 p.m. will be picked up the same day, and any referral sent after 2:30 p.m. may be picked up the same day or picked up the next day because it is a minor illness disposition. We do ask pharmacists to exercise their professional judgment to assess if a patient requires urgent support, and ensure that this is communicated properly. We do have a series of webinars that are actually going to be held with pharmacies again. We did a number of webinars last year where more than 400 pharmacists attended to pick up the kind of teething issues that we're seeing to ensure that the service runs smoother. Next slide. So in terms of identifying a referral, the process starts with the receptionist or care navigator, and the process begins in general practice and should be considered as part of the total triage process. And just an additional note for a number of questions that I always get is that there is a list of conditions here, which you can see on the left-hand side, the conditions that are suitable for referral and those conditions that are not suitable for referral. What we do say to the practices is that the use of this pathway is the choice of general practice, and they also have flexibility in choosing which conditions they are comfortable referring. So the patient will contact the general practice via telephone or online triage, and the care navigator or receptionist will assess the patient's issue against a list of conditions which are listed on the right hand side, which are suitable for referral under CPCS. So there is a GPCPCS toolkit for general practice and primary care network teams, which has been published by NHS England, which we will share post the call as well. Next slide. Okay, I'll carry on. You tell me when you're going to come in, Alison. I've forgotten which slide I'm handing over. So in terms of then making a referral, the receptionist or care navigator will make an electronic referral to the community pharmacy of the patient's choice, and the referral details are sent through to the pharmacy as an electronic message using as an electronic tool. So the funding for the IT referral mechanism in Greater Manchester has been sourced by the Greater Manchester Health and Social Care Partnership. So for EMIS practices, this is something called the Patient Access Connect template, which is a tool integrated into EMIS web, which includes a condition list and some triage questions to help identify appropriate referrals. So the tool pre-populates with PDS data and sends it directly from the EMIS to the community pharmacy Pharma Outcomes via an ITK link. And please note that patients are not required to sign up to this patient access app for the utilisation of this referral. For non-EMIS practice, there's a web-based referral tool called PharmRefer, works in a very similar way, but it's not fully integrated. So practices will be given a login, which will capture the same demographic information and allow a direct referral to the community pharmacy Pharma Outcome system. Unfortunately, there are currently no integrated tools on the market for non-EMIS practices. Next slide. So in terms of the pharmacist conducting the consultation, the pharmacy will contact the patient within 2 to 3 hours. The consultation is to be completed within 12 hours pending patient circumstances, and the patient should only contact the pharmacy themselves if they have not had contact within 3 hours. And it is that the patient should be contacting the pharmacy in the first instance if there is an issue. In terms of the consultation, the pharmacist will conduct the consultation. The consultation can be remote or face-to-face, and the clinical assessment is completed, presenting symptoms, relevant medical history and medication lists are taken, NICE CKS guidelines, summary care record and red flags are identified, and then the outcome of the consultation will be providing safety netting advice. It's managed in the pharmacy or escalated. If escalated, the pharmacist will make the call to the practice, and the consultation notes are sent as a PDF by NHS Mail to the referring general practice. Next slide. In terms of consultation outcomes, there are 6 key outcomes of the consultation. So the first one is advice only, and this is where the patient is reassured, and it may include the provision of written information or recommendation to use products that the patient already has at home. Advice and an OTC sale. So in this instance, the patient is encouraged to purchase a medicine OTC, which is suitably been recommended, and the pilot feedback shows this has not been a barrier for patients even in deprived areas. The third outcome is advice and referral into a local MAS scheme. So if the MAS scheme is commissioned and where the presenting symptoms of the patient are included and the patient is eligible, then a MAS provision could be made. But to note that, you know, not all patients are eligible for MAS and not all pharmacies are delivering it. So we don't want to send patients along with an assumption that they will definitely be seen under the MAS service, and there are variations in the specification across GM at the moment, and that's undergoing review. So the fourth outcome is advice and non-urgent signposting to another service or GP. So for example, it may be to an optometrist or the GP for a routine appointment, for example, dermatitis or eczema, which was previously treated with an OTC steroid but is no longer effective. The fifth outcome is urgent escalation and advice to GP, where the pharmacist considers the patient needs to be seen by their GP. In this instance, the pharmacist will contact the practice themselves, and in a minority of cases, a patient may need to be referred to A&E or 999. Okay, next slide. So I'll hand over to Alison from this point. Thank you.
Thanks, Lovejet. So hopefully that really quick whistle-stop tour showed you how simple it is to send referrals. I have been trying to answer a few of the questions in the chat box while Lovejet's talking, but we can address some of those towards the end. We just put this slide together really just to show the differences between minor ailments and GPCPCS. As Lovejet said, there are minor ailment services commissioned in some localities, but not all. I think Bolton and Oldham are the two localities at the moment that stick out as not having a minor ailment service. But your practice may be quite familiar and used to signposting patients to the pharmacy for minor ailments. So really the main difference between these two services is minor ailments is a locally commissioned service. You can continue to signpost patients for minor illness if you're confident in that patient's self-diagnosis and you don't feel there's any real need for a clinical consultation with the pharmacist. There's no red flags. This patient doesn't have any other serious concurrent illnesses, and that supply will continue as it always has been. Where GPCPCS comes into its own is where the patient has some symptoms and they're not quite sure what they are, so it needs more of a formal consultation and diagnosis, or where the patient has some clinical conditions, or there's some concerns about potential red flags where you feel that a clinician actually needs to speak to this patient to diagnose the issue and to make sure that any treatment that's provided or any advice that's provided is appropriate for that patient. The key difference is you will get the feedback into the practice if you do a GPCPCS referral. As Lovejet mentioned, you'll get the consultation notes sent back by email, whereas if you signpost somebody for a minor ailment service, you don't get that feedback. So hopefully that just explains the difference between the two services. In terms of GM deployment, Lovejet referenced this earlier, so we've done an awful lot of work across Greater Manchester to get to the point that we're at now, which is just less than 25% of practices across Greater Manchester are actively using GPCPCS to refer patients. There have been some comments in the chat box, as I mentioned, and I think Lovejet referenced it earlier, that with any new pathway that we bring into place, there's always going to be a period of time that it takes to bed in for everybody who's involved. So really encourage you, if you are live with this service, to have conversations with the pharmacies close by to you, just so that you can work together and work through any of those teething problems that you may have. So from a governance perspective, we've done a lot of work to make sure that everybody within Greater Manchester is on board with deploying this service. We've got a working group set up that includes all the key stakeholders. The procurement of the EMIS, Patient Access Connect, Patient Signposting App and Farm Refer is being managed by GMSS. And funding for that referral mechanism has been agreed for 21-22 and for 22-23 by Greater Manchester. In terms of scoping, all general practices in Greater Manchester are in scope, and we have some targets around deploying by March this year and then again by March next year. We've got our GM specific processes and escalations all agreed. We have some virtual outcomes training that's in place for general practice staff and also community pharmacy staff. And the working group team are delivering implementation training to GP practices twice a week, every week now, and have been doing since around about the beginning of November. So once a practice has engaged and supplied some initial information, then they can book themselves onto those training sessions that are happening regularly. We've done lots of planning, so we've refined our process to make sure that the steps that we're following when we deploy GPCPCS into a practice are tried and tested. And we're preparing monthly stakeholder reports and reporting into the system. In terms of engagement, Lovejet's been around the world in Greater Manchester, making sure that everybody's on board with this. So we've been to lots of different Greater Manchester forums and meetings, and it's great to be here with you guys as well in the Practice Managers Forum. Thank you very much for having us. And just reference in terms of engagement, there was some comms sent out in late November by your CCG primary care leads, referencing the Winter Pressure Access Fund and the PCN Investment and Impact Fund. Both of those two Potential sources of funding for practices include references to GPCPCS and requirements for practices to engage with GPCPCS. So there are some real incentives for practice to engage with this service. As Lovejoy said, this would usually be a presentation that we would deliver to engage with practices. So our next steps is for the purposes of today's session, if there are any practice managers on the session today who haven't engaged with GPCPCS and are interested in finding out more information, then you can contact either myself or Lovejoy. We'll put our email addresses in the chat box, and then we can direct you to the most appropriate lead for the area that you're in, and we can take it from there in terms of next steps. Just mentioning the IIF, there is a target number of referrals in the IIF, so each practice is asked to make 0.65 referrals per week per 1,000 patient list size, which is a little bit messy to understand, but a practice that's got a list size of around about 7,000, that works out at about 5 referrals per week. So those targets are starting to be measured, I believe, from the 1st of April. So another incentive there for general practice to get involved. We've got some resources on the last slide, and just to confirm to you that we really want to make sure that this service is a success when it is landed with general practice and with community pharmacy. So it is really important that we do make sure that we deliver that training to the staff within the practices that need to be trained. We have a deployment process and a plan in place to make sure that everything happens in order that needs to happen so that this service will be a success. So we really don't want practices to start to send referrals until they've gone through that process. And it's really important that you have attended that training session. As I said, there's lots of training sessions available to book on. So we're trying to make that as easy as we possibly can for practices who want to go live. And we've got quite a lot of practices due to go live in January and February. So we're hoping we're going to meet that 50% target by the 31st of March. Some resources there for you. We can share a copy of the slides with you, and then you can access those resources. And we'll stop talking now and take any questions that anybody may have. Thank you for your attention.
Wow, that was really formative, ladies. That was excellent. A lot of information. It seems like a lot of hard work's been going on, because I was just, as Lovejoy was talking and Alison was talking, I was thinking how many chemists we have, over 600 in GM. We have over 400 practices, and connecting is a difficulty, communication, and we're in a vaccination process where it is really difficult. So it's a lot of work going on. And I think a lot of the questions in the chat were due to probably that source material, if you like, of that the chemist hadn't responded, or whether, and this is the building growing pains, if you like, of such a big program or project. Even putting in that extra support, which is really benefit, is really difficult because of the size and scale that we're dealing with on a day-to-day basis. So did you say you're going to put in your details, Alison, and Lovejoy, just in case there's any issues? But I think it's a fantastic supportive measure that the chemists are doing. So brilliant work, and thank you very much for coming today and informing us of it.
Thank you, John. Just to add a final point, on the back of the feedback that we've had from practices, and of course, there have been issues, and I don't want to say that it's all smooth running, but we monitor now the referrals on a daily basis, the team do, and so there's phone calls that are made to each pharmacy when they're not completing referrals. And just to add that there are community pharmacy pressures out there, and I'm sure that you're aware of them. So we have now started to advise, the pharmacies that if you've got a problem and you won't be able to do referrals, please get in touch with your local practice to tell them not to send referrals in the interim until you're stable, or even to escalate it to NHS England to suspend the service. So, if the practices do have a problem with a particular condition, like I had a lot of feedback about earache, for example, then if you're not comfortable and you feel it's creating problems, then my advice is don't refer that particular condition over until we resolved it. And of course, me and Alison are available, that if you want to give specific feedback, we always welcome it, and we will use that to refine and make sure that we're communicating to all the pharmacies, to make sure that we start to get this smoothly embedded in the system.
That's brilliant. It really is, and thank you very much for coming and telling us about it. Like I say, you've given your details, and if there is any issues, then they can come to you for a bit of advice. We'll circulate your presentation out, which has got all your links and supportive information in as well. So it'd be handy for people to have a look at that. But thank you very much, ladies. That was absolutely fantastic. Thank you. And if there's no questions, I will move on, but thank you very much for coming.
Thank you. I'm just trying to work my way through some of the comments and put answers in the chat box, and then you've got them.
Fantastic, Alison. Yeah, because my chairmanship's not been the best. So we are running
no,
3 minutes over, and we're not too bad. And I've just got some bits and bats that I want to just put out to the group. So firstly, from myself, thank you everybody for coming and presenting at our meeting, and thank you for all your practice managers for taking the time to come to our meeting, because we know how busy it is out there, and we know what the situation is. And we hope that it's been quite helpful for you, and the support out there that you will hopefully contact and for the future be supported in. I just wanted to do an update for the group in the fact of there is a non-clinical workforce group that's been formed now by all the CCG leads in Greater Manchester from all 10 localities. And one of the things they were looking at is developing pathways for non-clinical workforce, so like reception, deputy practice managers, practice manager roles, and how to get people in those roles. So Claire's put a question in. If people can just submit that and vote on that for us, if that's okay. And then I've got the other question for me is these non-clinical workforce groups that are going on, we're looking for representation for practice managers, obviously, because this is affecting your roles and you manage these roles of reception, deputy practice managers. So we do want some representation for practice managers on the group itself. It's run by Sati Boyle, who's the Salford CCG lead for workforce. And like I say, all the workforce leads are there from each locality. So I'm going to put my details in the chat and just a bit of verb about what the meeting's about. And if you do want to attend that meeting, be a part of that meeting, have a say about these pathways that are coming into your practices, it's a great opportunity. So I'll put the information in now for the chat. So that was one thing. And then Claire's got my 2 other questions in. Is that right, Claire? And really, these questions were really around just around the practice managers meeting, and here we go. So basically, are the meetings on a monthly basis too often in the current climate? Because we know the current climate out there is very, very busy, to say the least. If I just leave that up for another couple of seconds, and then we'll swap round to the second question.
Oh, that's the only question.
Was that the only question? All right.
Yeah, because the other one was about the pathways. Right.
Okay, that's fine. That's great. That's great. So it's just to find out some information, because what we want to do is support you the best we can. We know at this current time, with the vaccination process that came out just before Christmas, that things are pressuring up. We know when we've discussed today around the job contracts that may or may not be coming into place around the vaccination itself and non-vaccinated members of staff. So we know that would be a further implication if that comes in. So we are aware there's a lot of pressures out there, and there's a lot of pressures coming. So if this meeting would be better off bi-monthly, then we'll do that. If you think it's better off monthly, and it is a good productive use of your time. However, what we could do is just temporarily do it. So for this time period, and maybe start up again in April if things calm down. So what we'll do is we'll take away your answers and we will feed back to you all. What I'll get is everybody's presentations who's presented today, and I will feed it all back to you all probably early next week. The other thing I wanted to say is I hope everyone's had a nice festive period and a break over Christmas, because when I was introducing it was one of the things I wanted to say. So I hope you have had a chance to have a bit of a break with your families, and I know it's probably going to be another difficult start to the year, but we will get there. And stay positive, and thank you everybody for attending the meeting today. And it's a close. Thank you very much. And if there's anything at all with anything that's been discussed today, please contact me. Okay, thank you everybody, and thank you everybody for speaking.